It's always good to report. Well, good morning, good afternoon, everyone. This is Tim Colbago from ImageIQ. I hope you're all doing well. As we were mentioning before the webinar started, spring has sprung here in Cleveland, and we are talking about this spring how to compliantly manage images and data in your clinical trial. So hopefully you're on the right webinar. This is kind of like that part where you get on the airplane and they go, this plane is going to Denver. And you're like, I've never seen anybody go, oh man, I'm on the wrong plane.
How did that happen?
So this is your webinar today. As we get started, just a few logistics things I think would make some sense to talk about. Tim and I have about a 45-minute presentation interleaved with a demonstration. So we're going to show you a live image-enabled EDC here today, which is super exciting, that Tim and his team use. We will definitely have time for questions and answers when you're ready. So as you can imagine with a webinar with this many number of people on it, we keep you all on mute so that we don't hear dogs barking, doorbells ringing, or inevitably, we were joking, somebody will put you on hold. So you guys are all on mute. The best way for you to ask us questions is to type them into the little GoToWebinar box, control box that you see. GoToWebinar has recently updated their software, which is great. But you need to find where the question box is, and you're welcome to type us questions. We will do our best to answer those at the end, if time will allow. If we can't get to all the questions, we're happy to talk to you afterwards. Drop us an email, or we'll reach out to you, and we can certainly answer your questions that way. We always get this question asked as a question, so we've gotten good at proactively answering it. The webinar will be recorded. Probably sometime early tomorrow morning, maybe even late this afternoon, we will have the webinar up on our Imaging Analytics University website. You can find it if you go to webinars, and you look at for historical webinars. All the webinars that ImageIQ sponsored are up there, and this one will be the latest and greatest webinar. So super cool. All right. Super cool. So let's get rolling. And why don't I introduce you to Tim, who's sitting next to me. So not to be confused, you have two Tims here today. And for those of you who've seen Monty Python,
we didn't bring Tim the Enchanted.
We did not bring Tim the Enchanted, but we do have Tim Crow with us here today, and I'm Tim Colbago. And Tim, thanks for being here.
Oh, it's great.
Sure.
It's very exciting.
A little bit of background, just so everybody kind of understands where Tim's coming from, so you have some context. You know, Tim works at C5 Research, a lab inside the Cleveland Clinic, and we'll let you tell folks about that a little bit. But Tim's got a wealth of experience in clinical trials, specifically focused in cardiovascular imaging, right? That's been an area you've spent a bit of time in. A little bit of time. And, you know, having contributed his experience in over 50 trials since he joined the angiography core lab at the Cleveland Clinic in 1991, Tim's really served many roles, right? I mean, he used to analyze images for a living and managed the core lab for over 13 years, right? The imaging core lab for over 13 years. And today, in his role at C5 Research, he really supports some of the other functions that go around a clinical trial: protocol development, study startup activities, RFP quoting, the business side at some level of preparing for a trial and supporting new technology initiatives to make things better. And that's part of why we're sitting here together today, which is really great. You know, on a personal note, it's always fun working with great people and great clients. And Tim, we love working with you guys for sure. And, you know, part of it is you're bringing such a fresh perspective to how, you know, technology can really move things forward, both from a quality perspective, which is always job one for you guys. I know, I mean, I can't tell you how many conversations we've had about quality, and efficiencies, and making things run better for your clients and your sponsors and stuff like that. So maybe before I do a little bit of the ImageIQ pitch and my pitch, maybe you could tell folks a little bit about the C5 Research Lab and what you guys do.
Sure. No, thanks, Tim. Yeah, it really has been a great collaboration with you guys. And so a little bit about C5 Research. We're an academic research organization within the Cleveland Clinic. We're about 100 employees strong, and we coordinate clinical trials from single center to multi-center trials internationally. And we've been in existence since the early 90s, 1992. And we have groups such as project management and clinical events committees and data management and statistics activities. And then also we have a very comprehensive imaging core laboratory, not only the one that I manage, but there's a imaging core laboratory that Anita Flynn manages there. That's more the echo and the MR and the CT. And then the one I was managing that is now managed by Bill Magyar was in angiography, intravascular ultrasound, which we're going to talk about today, carotid IMT, and other novel imaging. And so that's kind of where we are today.
It's all the leading edge stuff. It's great. Well, thanks for being here. And real quick about ImageIQ, we sponsor these webinars primarily, we do them for free for everybody because we want to educate people on the state of the technology that we work on a daily basis. We're a software company that really looks a little bit like a CRO, a little bit like a contract research organization that really specializes in imaging for the bioscience industry. And our main mission is to be imaging experts for our clients. So whether it's helping them write a protocol or developing EDC solutions for them or doing custom software analysis, we do everything imaging, and that's kind of our mission. Generally, our clients are focused on their science, right? And that's where they like to spend their time. So we like to make the imaging work go away for them and just serve their needs. And for those of you who haven't been on a webinar before, I'm Tim Colbego, CEO of ImageIQ, and just a little bit of relevant history here. Nobody likes talking about themselves generally, but a little bit of relevant history. Before I came to ImageIQ, I spent well over a decade building software for diagnostic radiology, both the hotel functions, patient check-in, scheduling, all that kind of stuff, as well as the imaging part of that, PAC systems effectively. So my passion personally is leveraging software technologies to make imaging more accurate, more efficient, and stuff like that. So our EDC platform that we're going to talk about here today and how it's been used at C5 is kind of an exciting thing for me. So we'll have a real good time. We always like to start these things a little bit with a story, and it's really funny. Brett Hoover, one of our guys, always gets the calls. We're like, Brett, whatever happened to Tim's whatever? And so I have a little bit of a story to tell you, but it's always relevant to the webinar. So the point of this story really is that if you have images without data or data without images, things get a little weird. So my lovely middle daughter worked her butt off for the last 2 summers flipping burgers. I say flipping burgers. She was making pizza. She corrects me. And earned her way to take a class trip to Paris. And literally, as we record this webinar, she is in Paris over spring break with 40 of her classmates. And she was all excited, Dad, I'm going to Paris. I'm going to take all these pictures. She's got her little point-and-shoot camera. I think that's actually the model. I think it's on the right clip art for the model. I'm going to take all these pictures. This is great. This is great. I said, Allison, that's wonderful. I said, but here's what you need to remember to do. At the end of the day, you need to grab a book and journal what you took a picture of because you're going to take so many pictures. And the whole trip's going to be a blur. You're going to forget. You're going to forget. Okay, if you're taking a picture of the Eiffel Tower, you'll remember, right? But the museums and the architecture and all the other things you're looking at, take time to write it down. And that's really the essence of why we talk about an image-enabled EDC today, is that, if you just have your imaging and you don't have the data in the context where those images came from, 2 years into a 5-year trial, you could get yourself in a little bit of trouble, right?
Misinterpreted.
You could be misinterpreted.
That's right.
On the flip side, if you've got the images and all the data and you don't remember how they go together or when this was taken, you run the risk of noncompliance and all sorts of things. So Allison is in Paris. Hopefully she will be home. She's having a great time, and hopefully she'll be home safely. But it does really speak to the fact that images and data together are worth way more than 1,000 words if you can do it right. And that's what an image-enabled EDC is all about. So what we're going to cover today is really 4 things, and we're going to do this hopefully in a unique and exciting fashion for all of you. The first thing we're going to do is talk a little bit about the challenges imaging introduces when you bring imaging into your clinical trial. We've talked to a number of people who would really like to use the power of imaging in their trials, whether it's in the cardiovascular space or visible light imaging, but they're a little bit afraid of the challenges, so we should enumerate those. Then we're going to talk about what makes an EDC an imaging EDC and what's special about that and why, if you have imaging, you really need to be thinking about this. And then we'll talk about the key areas where that adds value. Tim, that'll be mainly your role because you live this stuff with your team every day, right? And those folks are great, and they work really hard at all this stuff. And then we'll talk a little bit about compliance and data quality. Plus, we're going to do this all with actually a demonstration. Now, the system we're going to show you is a demo system. So, patient names have been removed to protect the innocent, aside from patient confidentiality in general. So you are going to see a demo system, but we're going to show you what it looks like, but it's a system you guys are running live here today. The system is named ICAS. So what's ICAS stand for?
It stands for Integrated Cardiovascular Analysis System.
Beautiful. And it's built on our EDC IQ platform. So ImageIQ has recently kind of made a little more public that we have this platform for building image-enabled EDCs. We call it EDC IQ. And ICAS is one of the first incarnations of what we built off that platform. So super exciting, super cool, and we're going to do that. So to get started with that, Tim, why don't you tell us a little about the trial? So everybody here, we have a tendency to talk to people who are really into science, and they love the trial part of it. What are you working on? So why don't you tell them a little bit about that, and we'll go from there.
Right. No, thanks. So yeah, we're now currently using the ICAS system for the GLAGOV trial. And the GLAGOV trial is a trial run by Amgen, and we're collaborating with them from the core lab perspective on this study. It's a global study, so we're running it internationally. We have 2 imaging time points that we're assessing, a baseline and an 18-month follow-up. We've enrolled 950 patients. We're now in the follow-up phase of that study. And those subjects have been enrolled from 230 sites worldwide. So this is one of the largest, I think it's maybe the second largest IVUS study done in this context. So
wow.
it's a big study, it's a big deal. So the study itself is looking at what they call a PCSK9 inhibitor, and this is an agent that lowers bad cholesterol to tremendous low levels, down to the 20s and 30s. You can read a lot of the publications that are already out there.
I know my numbers, 20s and 30s.
Yeah, I mean, it can get down there with other, statins and that sort of thing, but it's really shown some dramatic results from that perspective. So
I'm ordering the cheeseburger for lunch.
No, don't do that.
Okay, I'm just saying.
So anyway, the trial itself is an imaging trial. The IVUS is the primary endpoint of this study.
Which is unique, actually, isn't it, right?
It is. It is. Imaging endpoints are usually a secondary or observational or that type of thing. So it's a very exciting type of study to be a part of. So we'll be collecting the intravascular ultrasound, or IVUS, and the angiographic exams at the baseline, and then at follow-up just the IVUS. So the angio is, in this context, is used for screening purposes of the baseline study. Okay, we do some qualitative kind of analysis with those, but it is part of the ICAS system.
Sure.
So yeah, so that's where we are with that study. So to just kind of give you an idea of what that imaging looks like, just to kind of give this a sense of purpose.
Yeah, well, and IVUS is a little bit more of a less mainstream. People know CT and MR, but IVUS is a little bit more of
and it's used quite a bit in the cath labs during interventional procedures to see how successful they were with their procedure. But we've used it in these kind of natural history studies like we're talking about today. And it's a small transducer that they place inside the coronary artery, and they interrogate back through the artery as far as they can go. So we'll look at lengths of arteries up to 100 millimeters in length. Okay. So the imaging you're going to see here, the transducer rotates at 1800 RPM, and that generates a full motion video of 30 frames per second. So this is an animation of that, and it's just going to now merge into a real live, not live, but a real ultrasound. The center blue is the ultrasound catheter. The red is the blood flow channel. So again, we're looking at a cross section of the artery.
Right. I think this will replay too.
Oh, good. Okay. So the first border is the intimal leading edge, and the second border is the outer vessel wall of the artery, and then everything in between is the disease that accumulates in our arteries. Some more than others,
right.
But in this case, that's a moderate amount of plaque that you see there within this vessel, just to give you an idea. Yeah.
Cool. So that's the catheter.
That's the catheter transducer there, and that's the blood flow.
Got it.
There. Yep.
And so you're looking at
and so the core lab will trace that border and this border, generating areas and diameters and thicknesses between those two borders to generate the data. So that's the technique.
So what we thought we would do, since we promised you a demo, and we don't want to go too long without at least showing you some software, to show you what these images look like in the live demo site. So I'm going to press the magic escape button, and in the spirit of doing crazy things on webinars, I'm going to actually pull up the system here and show you a little bit about how the images look. Right? All right, and so now if we go in here and we find the right thing, I got to do the typing thing here. We'll find the right patient and bring this up. I think if I press that button, good things happen. And so what we're seeing here is effectively the web-based system loading, in this case, the baseline image and the follow-up image, which are relatively large.
Yeah.
Right?
So these can be up to a gigabyte in size for each time point. So on the left, you see the baseline pull back. Again, it's a full motion video. Tim now is just scrolling through it, through the whole thing to give a quick look at what that interrogation looks like. They interrogate from distal to proximal, and they do these cases. And it's an automatic pullback device with a steady 0.5 millimeters per second when it's playing full motion. Okay?
Got it. Yep.
Yeah. So that's what it looks like. Yeah.
Very cool.
And the follow-up is on the right.
And the follow-up's on the right.
Yep.
And they're married to each other.
Yeah.
And so when we get later in the webinar, we'll talk about how important that is and the data that comes with it. But for now, we'll go back to PowerPoint land. But we'll be back to this we'll definitely be back to this software, at some point here shortly. So we'll do that now. Let's see if I can actually make PowerPoint come back the way it's supposed to. Oh yes, we did it. So, look, to talk a little bit about the challenges that imaging introduces, and certainly your experience is well beyond mine in terms of the clinical trial imaging challenges. Just as a reminder, right? We all live under the guidelines that the FDA and the government provides for us relative to, being responsible with what we do for patient safety and how we conduct these clinical studies. And one of the things I just point out, for those of you who haven't read your Part 312 recently, or any other relevant part that might be right for you, as sponsors and as principal investigators and core labs, we're all responsible for being compliant with this stuff. And really, I shorten this, but to ensure that the investigation is conducted in accordance with general investigation plan and protocols. The key thing is, and I just point out to everyone, it says protocols. It doesn't say the study protocol. It doesn't say some protocols. You always have, when you're doing imaging, good imaging protocols, not only for acquisition, right, but for interpretation and analysis, right? That's right? And so you are responsible to be compliant with all the stuff when you have these protocols. So that's where the challenges really start to get introduced. And so we'll take, I think we can do this in 30 seconds, just to talk about some of the challenges that really imaging introduces. The first thing you've got to do is move these images around. While we're all used to tweeting and Snapchatting or whatever. I mean, you tweet a lot, right? And Snapchat a lot. While we're all used to doing that, moving medical images is a little different, right? And moving large image sets is very different. So you've got to deal with that. You have sophisticated acquisition protocols. A lot of these times, these protocols will deviate from standard of care, right?
Exactly. Exactly. So that's a big part of what's done in imaging trials, right? And creating that protocol that the sites have to follow to create a very consistent and there's no variability in the data across the board as long as they follow the steps correctly.
Exactly. And then once you do that, you want to do a precise analysis technique and report on that in a way that's consistent. So like my daughter in Paris, when you look at your images and you look at the data that goes with the images, you remember what you're looking at, and everybody's doing the same thing because you're trying to remove that variability, right? And I know that's something you guys measure on a regular basis. And
doing it, and then putting QA exercises on top of that to make sure that we are, doing that properly.
Exactly. And depending on who's reading your data, whether you're using a core lab or maybe using a radiology group or something like that, you've got this concept of transcribing the data. Radiologists or pick your favorite ologist, whether maybe you're doing dermatology or some other kind of visual lighting. You've got transcribed data that they're used to dictating. Well, who's transcribing it? How are they transcribing it?
When does the data entry happen? Who's doing that? How many times is it done?
How many times is it done? Yeah, which systems is it going in?
Right.
This concept of local PAC systems, where these, especially radiology, is being pulled into local PAC systems, and you've got to deal with issues about blinding, people and making sure that overreads are done correctly and patient, subject identification is handled correctly. There's all sorts of stuff. And a lot of people are doing imaging that's not radiology, right? I mean, people think, when you think imaging, everybody thinks CT, X-ray, MR, that kind of stuff. But we're running a number of trials, or assisting in a number of trials, where we're doing visible light imaging. You're grabbing a good quality SLR camera and taking medical photographs of wound healing, diabetic ulcers,
histology.
Histology, all that kind of stuff. So you've got all these challenges that have a tendency to show up when you're trying to do a clinical trial and you introduce imaging. And so then the question is, well, what pitfalls are there? Well, and the whole title of this thing is about compliance and how these software can help you. But look, missing time points. Some of these trials, especially the orthopedic ones, run a long time, 5, 10, 7, 10 years. And you've got time points that you've got to deal with. If you miss a time point, you run the risk of losing a subject.
Correct. Yeah, it's the same with the cardiovascular imaging trial. They can be very long as well. And the further you go out, the bigger chance you have of missing these time points, or even they do the imaging not in the same fashion. They have a different doctor doing the same day.
So, all sorts of craziness. And look, we don't have to go through all the details of all these things, but breaking blinding, failure to adhere to protocol, all your Part 11 stuff. It's interesting. I'm certainly a little bit of a student of Part 11 and how that works in terms of data security, and the fact that if you write something down, that's the original document, right? And technically, even if you scan it in, it doesn't necessarily have to be Part 11 managed. Imaging specifically has a tendency to all be digital. It never gets print it on film or put on a piece of paper.
Right.
And so Part 11 applies in just square away. And so you need to make sure you've got Part 11 compliant. And the worst place you can break compliance is, oh, yeah, I got the images transferred over. They were all secure, and it was audited, and that was great. And then I grabbed them, and I put them in this other system and looked at them. Okay, that grabbing is not Part 11 compliant, depending on how you do it. And that creates a big problem. And ultimately, it can be really significant delays. You know, imaging, and a lot of times, at least we see, is a very key component of screening. Right? You're going to use imaging to screen a patient, qualify them for the exam, and if you've got to wait 2 or 3 weeks to make sure it was QA'd correctly or not QA'd, you know, and then actually assess, that's a long time to wait to see if you've got a subject.
That's right, and if the site hasn't filled out CRS properly, or they've left things blank, and you have to go back and forth with those type of things. Right. There's a lot of delays that way too.
Yeah, and it's in those details. Plus, and we're not going to. We could do a whole webinar on all the other systems that could get introduced. And you'll talk a little bit about this in terms of where, you know, how the C5 team has evolved in their technology use, because you've been using technology for a long time. You know, you introduce the potential for image management systems to move images around. I like to call it the plumbing. Reading workstations, what are you using, and how consistent are they? And now you've got some kind of case report forms or electronic data capture forms, or you have an archive and analysis software, which ImageIQ likes. We're into that stuff, right? And tracking and reporting and monitoring. There's all these new systems that get introduced, and they all have to work together and be coherent from a Part 11 perspective, a compliance perspective, a workflow perspective, a data integrity perspective.
Yeah.
It's a little crazy.
And the data hosting, you don't have that on the list here.
Yeah.
But even the data hosting piece and the exporting the data eventually at the end of the trial.
That's right. Yeah. Exactly. Yeah, exactly. So we thought we'd talk a little bit about what makes an EDC an image-enabled EDC. The essence of it is pretty simple. You all know what an EDC is all about, right? It's electronic data capture somewhere in your system. But the key thing that makes an EDC an imaging EDC is that it integrates the images as soon as possible in the process and allows those images to stay with their data and with the people managing them the whole way through. It's a consistent package that goes through, right? So what ImageIQ has done is created this thing called EDC IQ, which is our platform, and ICAS is a manifestation of that platform, to do this kind of work. And it really manages the full life cycle of imaging from post-acquisition through the transport, through QA, which hopefully everybody's doing, review and analysis, storage, all the data capture stuff, communicating that to other systems, whether it's your biostat guide, your clinical trial management system, some other EDC. It allows for that full integrated experience. So even
communicating with the site.
Right.
I mean, we talked about that too. Communicating the QA or the screening process directly with the sites to give them feedback on the imaging.
Yeah, you said that's important for your site.
Oh,
right?
yeah.
They love knowing, you know, they call you.
They're waiting for it. Yeah. They want to know they did a good job. They got A on the paper.
Yeah, that's true. That's true. When you're able to show them and communicate that with them in a way that makes sense, it works out really, really well. Yep. So, Tim, why don't you tell us a little bit about, you know, before there was the ICAS solution, you were using technology in a lot of good ways, but it created some challenges for you. Maybe that'll set the stage for folks.
Yeah, so, you know, the slide you see here is kind of the component you saw on the previous slide, but without the cloud, encompassing it. But, you know, we've been doing these trials for a very long time and using several systems in concert to do that. And, you know, there were challenges around that, validating these systems or getting them to handshake or talk with one another and exchanging the information between the systems. And it's a well-oiled machine, and it worked very well for us. And but as the years have gone along, and even more recently, we really realized that we need something in this century. And so that's what prompted the ICAS project, and allows us now, allows our analysts and readers to focus on the reading and not on all the logistical stuff and the challenges that are around the data capturing and integration with all the pieces. So it's really, it's already shown a great promise. We're really excited about it. And that's kind of where we've come, and now we're going to kind of look away from it and go to the future.
Well, I think a lot of lessons learned too. I mean, we've had so many best practices, and to translate them from what we were doing with all the
put that into the ICAS
and put that into that ICAS solution was, well, in part challenging, right? I mean, we spent a lot of time at the whiteboard and thinking through, and frankly, version 1, we were like, ooh, that's not quite right. Okay,
Yeah.
so, we're on version whatever we are on now. But, that was kind of an interesting thing. But I think those lessons learned for folks who are kind of watching the webinar here, is that, one of the worst things you could ever do for a client, in my experience, is automate their bad workflow. Right? And what was really cool about when we were working with you guys is you had such an optimized workflow that it was easy to move that into a fully image-enabled EDC. You understood it and you got it, right?
But along with that, not to belabor this, but we also discovered ways to be more efficient and be better when we went through this exercise. There were ways that we didn't realize or were aware of that we could do and tools we could use, and therefore it even is better than what we had before.
That is super cool. Yeah, and that was a fun process.
Yep.
So let's do this. We're going to kind of do the demo thing, and now I'm going to be doing the in and out of PowerPoint thing.
Okay.
So what we thought we'd do is give you a little bit. We talked about those complications, and Tim, you can show everybody how you're managing some of this stuff. And you're welcome to drive the mouse, or I can. But the first part of any image-enabled experience is getting the images transported from the site to where they need to be. It might be a central reading core lab kind of experience. It might be where your radiology or other teams are. You guys are using a really good solution out there, AgMedNet, that we've integrated with. And
yeah,
we do a really nice job.
We've partnered with AgMedNet now for a number of years, and it's been great that collaboration has worked out with you as well. And yeah, they have an imaging transport solution that allows sites to upload the imaging and attach a CRF that they have filled out with some brief information, but the information we need is a core lab, and then that is all together as a package sent to the ICAP solution.
Yep, exactly. Yep. Exactly. So whether you're using something like AgMedNet, kind of that more proprietary solution, or your team's receiving images on CDs, we get that a lot, or you're receiving secure DICOM, or you've implemented a VPN, or something. One way or another, you've got to get the images off the site, right out of the site, and that image transport is important. So what we're going to show you is what the ICAP solution does relative to the AgMedNet integration, but keeping in mind that when you're looking at an imaging EDC for yourself or putting that into place, one of the things you want to do is be flexible. You don't want to disqualify a site that's got good subjects and a good PI because the IT team says, there's no way I'm hooking up secure DICOM to your play. I'm not putting a hole in the firewall. We see that. Now, I know that it's changing a little bit.
Yeah, I mean, we've seen
while you're talking about this, I'm going to switch over to the
Okay, that's great. No, we've seen a tremendous acceptance of the image transport technology, whether it's AgMedNet or other vendors, because there are others out there. Over the years of our IVUS trials, we started, with like a 20% of our sites would participate in electronic transfer. And before this call, I went and looked at the data, and it showed that Glagov is transporting 96% of the cases electronically.
Right.
So sites get it, and they're more accepting of it, and it's really the way it is. And sending it by mail is just not acceptable.
It's not acceptable.
Yeah,
we still run into that a little bit where we get stuff by mail, but it's good to see that it's moving the right direction.
Yep.
So the thing we thought we'd show you here in the ICAP solution is that concept of the images and the data married together. We've selected a particular subject in the study here, and down here you can kind of see their audit trail, kind of the user view of the audit trail. And what's critical, I think, here to show, and Jim, feel free if I'm not saying this quite rightly, but the audit trail starts with us receiving that data from the site through this interface, and you have evidence that the angio is received and the IVUS is received. And what's important is, look, mistakes happen. You spend a lot of time dealing with mistakes and stuff like this. So the question is, what came in from the site? And then based on what came in from the site, do you need to make a correction? And again, you don't want the images and the data to ever leave each other. So this is letting you manage that all together.
Right.
So we have the ability here to show you effectively a locked down PDF of the data that was typed into the system at the site at the time it was received automatically.
Correct.
Right.
Correct.
And so what's that give you? What's that do for you guys?
Well,
other than you got PDFs, which is
no, I mean, at the site level, they're entering this data in, and there are edit checks that are incorporated into that process. And if they leave a field blank, they can't send it to us. So at that first step, before they can even send it, so we have those kind of processes in place. Then when we receive this data, it is then automatically uploaded into the system, and we have it. This is one of the screening forms when we screen these imaging cases, and that data is now automatically populated into that screening form. We in the core lab no longer have to key this in, which we had done in the past.
Right.
So as you can imagine, that's a huge advantage. Right. And so all we're doing is focusing on screening the image and its quality, providing feedback, and sending this form back to the site whether the imaging was accepted or not accepted.
You know, that's a good. I think that's a good segue into kind of the next slide. So let's go back to the PowerPoint part of the movie, and talk about that quality assurance. Right. You know, and there's some key questions you need to ask yourself around QA, whether you're sponsoring or contracting out your imaging, or you're core lab and you're doing it yourself. But is QA being done? Is it being done in a timely fashion so that you can make corrections? Is that auditable? And I think to your point, you know, do you have consistent workflow and communication on failure? Something will go wrong. It happens.
Right.
It's life.
Right.
And how do you communicate that back? And, you know, again, there's PHI controls. We don't have to get into that. But that whole workflow is an important part of what happens, right?
Absolutely. It has to happen quickly and consistently. If there are people out there that are doing imaging trials without a QA component, I think they should rethink it. It's an important piece to really quality. We talked about it at the beginning. Is another piece to provide the quality in a trial that you need. And if you're constantly doing that as imaging comes in and providing that feedback in a consistent fashion to sites, you're going to win. It's going to be good for everything, good for the whole trial.
So in your imaging EDC, you can actually look at the image in the EDC for QA and do that kind of stuff. But ultimately, what you're filling out, and we'll go back to the PDF just to make it easier, is you're clicking that button right there, acceptable or not acceptable, right?
Correct.
Right?
Yeah, exactly. You're just clicking that button. If it's not acceptable, there's some boxes below that might have reasons why it wasn't. If it's something outside those boxes, there's a place for comments. But it really streamlines the process.
Right.
And then you get through this very quickly.
Right, and another hidden benefit of this, you know, we hear a lot in the industry, and there's a lot of buzz around big data. Yeah. They were talking, oh, big data and the Internet of Things is kind of the, you know, all this stuff. This is where big data is just a bunch of check boxes. Yeah. At the end of the day, of knowledgeable people making assessments and storing that in a way that you can start asking intelligent questions. So when you move into this review of IVUS interrogation and you have these checkboxes, you can start asking questions for the next trial or the next phase or the follow-up. It says, listen, 80%, you know, it's the old Pareto analysis, right? 80% of our imaging experience is failing because of these 20% of the problems. Okay, maybe we can improve training. Maybe we can improve compliance somehow. Yeah. It takes people money, time, and frustration.
Well, and in fact, we can generate reports of this kind of data, you know, non-acceptable data, for instance. Right. Sponsors are very interested to see that, and then we can go back and re-educate and emphasize to sites, you know, if they're trending through certain things, right. Then that reporting is really powerful.
Right. And with the imaging here, then you have the images right there, so that you can show the sites what's going on and show and explain that stuff. So that's it's an important step. All right, so now we're going to talk about image review, and there's a number of things that you have to deal with when you're dealing with image review, and it's especially important when you have specific measurements you want to make, right? So one of the things you've got to worry about is consistent technique in your image review. You know, a lot of people use a lot of different PACS kind of software. You know, so whether you've got eFilm or Cyrix or something like that, you want to measure an angle. How are they doing that? So you got to make sure you've got consistent techniques. You need to make sure that the measurements are clearly defined, so that when you're asking someone to measure the size of something or something like that, you know, you're doing the right thing. I know you guys measure some. We'll show them, right? You measure some different distances between things, right? And then the other question is, if you have that, how are you doing the reporting, right? How are you transcribing that report? How many systems does the report touch, right? If it gets transcribed and then gets cut and paste, and you don't want to be doing that, and that's kind of crazy. So this is really, like I said, a cool part of the solution. So why don't we show them a demo of how this works? And I think you're going to start with showing them how you do the matching, or the anatomical matching? Is that right? Okay, I'm going to pull that up while you explain what you're going to show.
So, yeah, in this technique, you know, we have 2 time points, as we described earlier, and a baseline and an 18-month follow-up. And the first step in doing this analysis is to match the segment that was interrogated by the IVUS transducer at the 2 time points. So we know we are comparing apples to apples when doing this analysis. So this is, as you see here, this is loading up both the baseline pullback and the follow-up pullback from this subject. And what the analysts will do in the core lab is they'll select, a starting point and then a stop. I'm just going to do it quickly. I'm not going to go through, what we're actually looking for, but for the matching of these two segments. So it would in practice be much longer than this. It would be more like 50 to 100 millimeters, like almost this whole thing. But for demonstration purposes, let's.
Okay, so you've just matched the anatomy.
I've just matched the anatomy, and so
I'll type in your password.
Type in my password, please. That no one knows about, but me.
Right.
And so now save that, and it goes automatically to the baseline pullback for analysis.
Oh,
what that has done now, and just that quick process, we don't analyze every video frame in these cases because we'd be analyzing thousands of frames.
Right, these are big. Yeah.
These are huge files. So our methodology is defined to analyze 1 millimeter segments throughout the pullback. Okay. And that provides us the power we need to do our analysis. Okay? And so this is the first image in this baseline pullback. And to do the analysis, we click on, the first step is to click on EEM measurements, which is the outer vessel wall of the artery. And so the trace.
Can you do that from over there?
Yeah, I'm good. I can do it.
It's not that your highest quality circle.
No, I'll probably get criticized when I get back to work. But and then the next step is to trace the luminal border, so which is the inner border tissue, if you will, at this space.
So now the cool part about this, I know this seems simple, but when you see people who do these measurements for trials on a regular basis, and you see what they do, they make the measurements and they're writing stuff down, and so
right.
The fact that these numbers are on the right, auto-populated based on the measurements,
exactly,
is not only a good quality thing, but it's an efficiency thing, and there's all sorts of good that just happens that's kind of behind the scenes.
Yeah,
right?
the analysts love this kind of
kind
of thing. So this is really beautiful. So. And then we have a calcium score. It's not important what those values mean, but we also have that as an assessment. And then there's a non-analyzable field here. If the image was poor for whatever reason, a lot of calcium or whatever reason, we can provide that down here. But in this case, the image is fine.
So when you say the non-analyzable region, that's because it passed QA.
It passed QA as an exam, as the entire exam, but this single image may have a large branch site that's here, or it may have a large piece of calcium that calcium in an ultrasound shows shadowing, and so the tracing would not be accurate. So we throw those kind of images out.
Got it.
Okay.
Yep.
And so then we sign off on that image. It shows us the image that are required for analysis.
You can't sign off yet.
So I can't sign off yet, but that's fine.
That's good.
Yeah, that's good. That's good. So then it would just go from image to image throughout this to measure. And I go to the next one, I go to the next one. Yeah, until I finish that case, I sign it off, and then I do the follow-up.
Okay, and that measurement experience is controlled, right? This is how you do the measurements, and so you get a more consistent product, right?
Exactly.
Super cool. All right, so now if we go to the next slide, hold on, I got to do my escape trick again. Oh wait, I think I can do it from over. Oh, I did the full screen thing. All right, so let's go to the next slide here. Right, so the next part of this story is access control, right? So that, ultimately, so now you've got somebody who did the measurements, and in general, you need to control the access to the data. Who's allowed to do what, like you showed, you signed off, and we had already assigned ourselves as a reviewer.
Right.
The workflow of that and the timing of that access control. At what point in time is someone allowed to see something? And what are they allowed to see? Is that a fair way to say it?
That's exactly right. And so with our process that we've incorporated in the lab, we have a multi-review process for all our imaging. And so our first reviewer, which you saw what I was doing just now, they perform the matching and the analysis and all of that. That's all that stuff. And so then they'll sign off on the entire case. And the next step, a second reviewer comes in and reviews this case. But they do not have access to the measurement tools. They are only allowed to review the images with the borders that were traced by the first reviewer. Right. And then they can annotate comments on the image. They can put arrows saying, I don't agree with the border at this place and what have you. And those, they don't mess with the values of the data. Right. It's strictly an annotation over the image. And so these are flagged, and then once they sign off, it goes back to the first reviewer. Got it. And so it goes into their queue. They can come back and make those corrections. okay? And then the final step is a physician reviewer. So the physician will sign in, because that's in their queue now.
Right.
They'll sign into this case, they'll review it, and if they agree with everything, great. If they disagree with a particular image, they can annotate as well. That eventually goes back to the first reviewer. Again, they're the ones that own it.
Got it. So in this case, you can see this is where we were. I just picked up a different case, and it's clear that this hasn't been signed off, and you can keep working on it. But if we went back here and just picked another group, let's say this one, another case, right? What you can see on the background of this guy, as it's loading both of these large data sets, what you can see on the background of this guy is this little kind of like watermark read-only stamp.
Exactly.
And at this point, I'm not doing anything to this, and you can't make changes, and that access control is critical so that you get
correct. That's correct. But down below, we have a comments box, so we could comment on whatever about this case, but it wouldn't mess up with the data at all. So.
And as we've kind of been the theme here, right? The data and the images stay together the whole time.
Exactly.
So you're always doing the same thing with the same group. So that's super cool.
Yep.
And so that's access control. And let's see what comes up next. But in terms of things you need to know about an image-enabled or an imaging EDC is this concept of interfaces. People ask, what goes from where, right? And so, one of the key things ultimately, and it's really a tough place to be when you're in imaging because you make pretty pictures, right?
Right.
But the ultimate parts about this stuff is people want to see the data, right? They need to see the data. They need to know what the data is about and where it is. And how do you get that into another system? Biostats folks or stuff like that, right? And so you need to be able to do that. And there's a lot of ways to sort of accomplish that. But even in something as simple as the ICAS system, where you've only got 2 time points, right? So we've run trials where you've got like 7, 8, 9 time points, multi-modalities, all that stuff.
Yeah.
In this case, the ability to have the imaging and the data all in one place lets you do something simple like this, right? So you get the magic analysis database, and you pull it up, and Microsoft Excel starts, which is always cool. You can call it a database, you can call it Excel, but you get all the data that you need to give. All the stuff that was pre-populated is this available.
That's correct. And it's only that data that has completed the analysis process all the way through to MD sign-off. So it isn't all the data that's being reviewed at different steps along the way. So depending on your particular trial and your needs, but that's the way we've set it up for this.
Yep, that works out really well. And
yep.
then the last thing we've got to talk about here, and then we'll jump to some of the questions, but is that whole Part 11 thing, right? Yeah. Everybody's talking about Part 11. And look, the challenges imaging brings is that you generally manage them outside of your normal workflow. It's not like getting a lab. It's not like getting, an oxygen level or a patient pain score or range of motion score or something. I mean, you're really, right. You've got these images you got to deal with, yet you're still beholden to all the Part 11 parts of the universe. Auditing, obviously, data integrity, and I got to tell you, we've talked a little bit about PAC systems since I lived in that world. There's not a PAC system I know that does data integrity at the level you would want to do it for your clinical trial. Right? Ultimately, Part 11 says you need to make sure that that data that you acquired wasn't inadvertently or advertently, nobody would ever do that on purpose, but inadvertently at least, modified in such a way that changes your results, right? And
well, I mean, these are clinical systems for the most part, right?
Right.
So they're designed for that environment,
right,
and not for the rigor of compliance that you need in a research environment.
Exactly, and you're optimizing different things. The clinical systems are optimizing productivity, protocol, that kind of stuff. Yep. In the research systems, it's a little bit different.
Yep.
And access controls are important, right? I mean, you don't want, like you look at a PAC system. One of the things that ticks a radiologist off the most is when they can't see the relevant priors to what they need to look at. In a clinical trial, showing them the relevant priors could be a really bad thing, right, depending on the protocol, right? Right. So that's kind of a big part of this, and so you need to really think about being careful when you get into that space. And I mean, there's a lot of great PAC systems out there, but holy cow, you really got to watch it. So I think, to kind of wrap up here, and we're doing really well on time, and we're just about to the end, actually. I think we got a couple more slides. Look, if you're looking for an imaging EDC and you start thinking about all the things like efficiencies that this can bring you, I think there's a bunch of stuff you got to think about. You need to make sure it supports a QA protocol, right? You need to make sure it's customizable to the measurements you need, right? Like you said, you guys have we didn't get to talk about it a lot, but the order in which you assess those images and do those measurements is important for consistency and that kind of stuff. Make sure it auto-populates your metrics. The worst thing you can do is have somebody transcribing numbers and transposing them, or cut and paste, or fat fingering them, right? I mean, yikes, it's slow and it's airphone, right? That's silly. Okay, this is the blatant ImageIQ plug, but make sure you have a framework for automated analysis. You know, we are starting to move more and more into introducing automated analysis into the process, even if it's for something as simple as QA, right? Where you can look at, you know, did we get the full field of view? You know, do we have good contrast in the image? I mean, there's all sorts of things you can do in an automated fashion that can remove a lot of things from this. You know, it doesn't work everywhere, but where it works, it's really good. Part 11 is important, obviously, right? Think about how the thing's installed. The system you saw here was a cloud-based system. We happen to be hosting it in the cloud, have survived several audits relative to that, because it's a little scary for some people. But, you know, if you're going to do cloud-based, make sure you've got good controls and all the audited stuff. If someone's going to host it in their data center, you've got all the data center issues to deal with, and you're responsible for auditing them. If you're going to self-install and do this yourself, make sure you've got even more work, but make sure you got the right IT support like you guys have. Yeah. You guys got a great IT team over there. You know, make sure you've got all the IT support you need to connect to the sites and get stuff down. So, you know, ask yourself those questions. Make sure you have a good archiving strategy, right? Because ultimately you need to know who's responsible for hanging on to these images and for how long, right? And very honestly, burning them to a CD and throwing them on a shelf in the back works. But what if there's a fire? What if there's a flood? What's your disaster recovery? Are they in two places at once? There's all those kinds of things you need to think about, and Imaging EDC solves that for you, kind of out of the box. And if you do all those things, I think the ROI case gets pretty easy to make, right? Because there's a lot of that overhead. So, so we're kind of at the end of the story. We got a couple questions, but Tim, thanks for being here. And I know you know a lot of people worked really hard to put this.
Yeah, no, I want to take just a second. I really, you know, Tim and I are sitting here representing a team that really went through the blood, sweat, and tears of development of ICAS, and we need to really acknowledge those people. You know, the ImageIQ group with Nate Tenley and Brian Graff and others, and then the atherosclerosis imaging core group, Bill Magyar, the manager, and Carrie Lane King, and Aaron Mayock, Mike Simmons. You know, without that core six, this really wouldn't happen, and we really need to thank them for getting it to where it is today.
Yeah, absolutely, absolutely. So Tim, we got a couple of questions. So I'm gonna give you the one here. So the one question is, what type of clearance and validation did you have to do on this system, right? In terms of FDA clearance, scientific validation. I'm assuming that's what they mean by that.
Yeah, so, yeah. I mean, from our piece, I think I'll give you the other piece.
Okay.
But from our piece was, you know, evaluating different tools and making sure that, you know, it was providing the answers and the numbers we needed for the kind of analysis that we were doing. So, you know, we did a lot of that legwork at our end, and then incorporated that into, you know, how this was going to work. And then you guys were more on maybe some of the paper pushing side, although we're doing some of that too. But maybe you can comment on that.
Paper pushing is not good.
I shouldn't say that, right?
No, it's fair. But what we like to call it is evidence that you did a good job, right? I mean, you know, at some point, what we had to do from a validation perspective is make sure that all of the things we warranted that the system would do from a good software development practice, whether it's 1345 in the ISO space or whatever, that it did. So, for example, we warrant that it's Part 11 compliant. Okay, Part 11 is very prescriptive on the thing. Well, Part 11 supportive are very prescriptive on the things you have to do. So, to give you an example, one of the things Part 11 talks about is you have to be able to detect and identify if data has been modified inappropriately. Right? So we did validation tests where we went into the system and messed with the numbers, that you did a measurement, changed the numbers somehow in the database, and then made sure that the system reported that properly, right? And we went through that validation, and then the paperwork part of it is that there was evidence that we did that. So we had to run that level of validation and stuff like that. So that was very important. Yeah. We got another good question is, you know, is this system compatible with REDCap? I'm not sure if you're familiar with REDCap or not, or
I am familiar with REDCap a little bit. Okay. I mean, this is a data management module for housing data. So we could certainly handshake with REDCap, whether it was an export-import type of thing, or maybe programmatically, you know, through a click of a button goes into a REDCap level.
REDCap level, yeah, absolutely. So, sure. So I can't say that we've integrated the EDC IQ platform into REDCap yet. I mean, that would be unfair to represent it that way. But I would tell you that if you look at, for example, the integration we did with the team at AG MedNet, that is a real-time interface. And so RedCap supports those kinds of interfaces. So, yeah, compatibility with RedCap is something that's easily explored. I think it's probably the best way to put it at this point. So,
sure.
I'll tell you what, it's 5 to the hour. We want to let these folks get to either lunch or their next meeting on time. So we will let everyone escape and go from there. But everyone, thanks for attending. Tim, again, thank you for being here, and thanks to the team over at C5 for letting you for all the hard work and springing you to let you spend the
and if people have questions afterwards, I encourage